Welcome to Hospital Rounds. I'm Kirsten Newlon, Director of Communications and Development. I'm here with Tara Harmon, our Cardiopulmonary Manager, and we're here to do a Hospital Rounds video on our Cardiopulmonary department. So just like every nurse and doctor has to round on their patients to ensure timely care and keep their patients up to date on their care plan, so we are rounding on our units and departments in the hospital and throughout the community to ensure you, our community, has access to information and updates about the services that we provide at Hillsdale Hospital. I'm excited to be here with Tara today. Welcome, Tara.
Thank you.
Yeah, can you introduce yourself for our community?
Yes, I'm Tara Harmon. I am the Cardiopulmonary Manager here at Hillsdale Hospital. I have been here for about 16 years. So,
wow,
yeah.
Great.
Yeah,
have you always been in this department?
Yes, I have. I started out as a respiratory tech while I was in college. Amazing. And then worked my way up. So,
yeah, that's wonderful. Well, you do a great job of leading this department. We're going to kind of go through the department, show a few different spaces that we have here in the hospital. But I think that first we should talk a little bit about how this department really is in coordination with a few other departments here in the hospital, as well as our pulmonology clinic out at Three Meadows with Dr. Martinez. Can you tell us a little bit about how those teams work together, and then also what we do on the inpatient side?
Yeah. So what will happen is a lot of times we'll get a physician order from an outpatient, usually a pulmonary clinic. Okay. And then they'll come in, have a scheduled appointment. So we'll either do stress testing, pulmonary function testing, pulmonary rehab, cardiac rehab, things like that.
Yeah. So, okay, that's great. And then in the hospital, you do some very direct patient care as well. So what role do you play in the different departments throughout the hospital to care for patients?
So with respiratory care, we are like the main, not the main, but we're pretty much at every critical situation that might come up here at the hospital.
Absolutely.
So whether it's an ER, CCU, it could be an X-ray, wherever, we're going to be called, and we're the ones maintaining the airway for the patient.
Yeah,
so
absolutely.
Breathing for them, making sure that they're comfortable.
I'm excited to be here with one of our cardiopulmonary staff members, Kiera. Welcome, Kiera. Thanks for joining us.
Hello.
Can you introduce yourself to our community?
Yes, my name is Kiera Hodge. I am a respiratory therapist. I have been here for almost 18 years.
Wow, lots of time here at Hillsdale Hospital.
Yeah.
Have you always been in this department?
Yes, I have.
Wow, so you are a pro. Well, Kiera is going to share a little bit about diagnostic respiratory therapy today with us. So can you show us around this room, tell us what the purpose of this room is, and some of the things that we do here?
Yes. So primarily we do outpatient testing in here. So this machine behind us here is a pulmonary function test. We call it a PFT.
Yes.
That helps us diagnose different lung-related diseases. Tells us how the lungs are functioning. It helps with diagnosing of like asthma, COPD, those types of things.
Yeah, okay. So walk me through what a patient would need to do when they were going to have this test.
So they wear some nose clips, and all of the breathing is done with your lips tightly around a mouthpiece.
Okay.
And we just have you do a bunch of different types of breathing.
Okay.
So we have you take like big breaths in, blow it out, and all of that. But yes, we walk them through it the whole time.
And are they enclosed in this?
For a small portion of the test, they are enclosed. It's not terrible for most patients.
Yeah, and it's clear.
So it's kind of pretty decent space. Every once in a while, we'll have someone who can't do the door closed. Yeah. But we just skip that portion of the test. Okay. And then we do the rest of the test. So
So making it as comfortable as possible, I'm sure.
Yes.
So you mentioned that this diagnoses lung diseases. Can you give a few examples?
COPD, asthma are like the main ones. We do them sometimes for like medication changes. Just to see if there's any change with that and how disease is progressing. Like fibrosis. Any like masses, things like that. If someone has found something on a CT, we generally do one of these to kind of get a baseline for the physicians.
Okay. So I'm assuming that these are typically ordered by either a primary care physician or maybe a pulmonologist. Okay. So Dr. Martinez, our new pulmonologist out at Three Meadows, I'm assuming is going to be ordering a lot of these. What would make a patient kind of maybe more likely to need a PFT?
I don't know. Obviously, like smoking history.
Okay.
Like any sort of like lung history of a patient who's had grew up having asthma or a job maybe.
Occupation that's around smoke a lot.
Yep.
Maybe. Okay.
Factory work is a big one in the area.
That makes sense.
Farming. Is another big one.
Yeah, that's a good point. All right. Well, this is wonderful technology.
It is.
And definitely makes the experience as comfortable as it can be. What else do we have in this room for diagnosing?
So over here we have stress testing.
Okay.
So there's several different types of stress tests that we do over here.
Okay.
So we have the treadmill here, obviously, and that is one of the primary ones. And then we do some chemical stress tests where we put an IV in.
Is that instead of the treadmill?
Correct. So a patient that for some reason can't physically do the treadmill.
And so if you have, any kind of mobility challenge, the chemical version of it, is it just as good? Is it different?
Oh no, it's just as good.
Okay.
Yep. And then we also do stress tests that include imaging along with them as well. So we do a portion of that over here, and that could be done with the treadmill or the chemical. Okay. And then they are here from the radiologist area, and they do an injection.
Okay.
And then they have a little wait time once we're done with them, and then they have some imaging done.
Okay. So it's
to help with any sort of blockages, anything like that.
So coordinating with radiology, with nuclear medicine, that team over there. That's great. What kind of symptoms might a patient be having where that might lead them to needing a stress test?
Chest pain. Patients with high blood pressure. Sometimes even just like a high family history.
Okay. Shortness of breath.
Yep. Shortness of breath is one. Abnormal EKGs.
Okay.
Or like other diagnostic testing that was done. Those are like the main.
Yeah. So once the stress test is finished, I'm assuming the pulmonologist is the one who kind of evaluates that.
No, actually, the stress tests are done by either. We have two physicians here that do them. Currently, would be Dr. Owusu and Dr. Baker. Our main one. Dr. Owusu generally only does them on certain days with his patients from the office. And then Dr. Baker does the rest of them.
So they can read those tests and evaluate the results. And then what kinds of diagnoses are coming out of those tests?
We have found like blockages and stuff like that, where patients have had to go
like a blocked artery.
Have stents placed. Obviously, we specifically don't. Usually see a lot of that because a lot of, especially the ones with the imaging involved, it's a multi-day test. So the full picture isn't done by the time they leave us.
But you obviously play a critical role. Are there any other kinds of diagnostic tests that are done here?
Yes. So we do heart monitors. So we call them, we have event monitors or Holter monitors. It's a little monitor that they would wear on their chest. They go home with it, and it just records everything that the heart does. And again, that could be for chest pain if a patient feels like their heart is like racing for no reason, skipping beats, just anything funny.
It'd be scary.
Passing out, syncope is another big one for those.
We are now in a new space. I'm excited to be here with Lacey. Welcome, Lacey.
Hi.
Can you please introduce yourself to our community and tell us what you do here at Hillsville Hospital?
Yes, I am Lacey. I'm one of the respiratory therapists. I've been here 11 years.
Amazing. Have you been in this department the whole time?
Yes.
Wow, that's wonderful. I know that I see you a lot of times with patients walking down the hall, and you provide great care for them.
Thank you.
So where are we? What is this space?
We are in the cardiac and pulmonary rehab.
Amazing. We have some different exercise equipment around here. So tell us about cardiac and pulmonary rehab. What's the difference between those?
So the cardiac would be for any patients with any heart problems. Or patients who have had heart procedures, so like stents placed, open hearts, heart transplants.
Wow.
And then our pulmonary would just be patients with lung problems. So COPD, asthma,
pulmonary fibrosis, lung
Gotcha.
transplants.
Yeah. So any kind of heavy condition or surgery,
Yep.
Recovering from that, I'm assuming. And I know that you guys have kind of an element of counseling involved, or maybe lifestyle coaching, you might call it.
Yep.
So tell me about kind of the coordination between that. Obviously, there's some exercise here where it's the actual rehab, and also
Yep.
maybe kind of looking at what can a patient maybe improve to continue improving their quality of life as they kind of
Yes.
adjust to some new challenges.
So we also offer, if patients want to meet with Denise, our dietitian.
Yeah.
So she helps them with that aspect of it.
Okay. Awesome.
We help people with smoking cessation if they need it.
Okay. Yeah, because that's definitely a part of it sometimes, is
Yes.
kind of, which can be a very difficult journey and obviously personable to every different patient.
Yes.
So I'm sure that you provide great support here. What is kind of the hands-on exercise part of that? What role does that play?
So it just helps strengthen people's hearts, lungs up. Also just kind of makes their everyday activities of living easier for them.
Especially if they've been struggling with a blockage or,
Yes.
or a lung issue or something like that. Yeah, I'm sure that's great. Can you give me some examples of the types of exercises that you do with patients here?
So basically these are the ones that we do.
We have a classic treadmill,
Yep.
I see.
Treadmill. This is what we call a new step.
Okay.
So kind of like stairs, but sitting down. And
Okay.
then we have our bike,
Great.
which you can do your arms and legs on.
That's great.
And you can do one or the other if you can't do both at the same time.
I know we usually have maybe a TV going, or,
Yep,
or
play
some
music.
music or something going on to kind of keep things interesting. And
Yep.
obviously, sometimes there's more than one patient here at a time, correct?
Yes, we can have up to 4 at a time.
Okay, wow. That's great. Do they kind of get to know each other, have some
They
camaraderie?
do,
That's
yes.
great.
Yep. And we do try to separate like our cardiac patients and our pulmonary patients,
Gotcha.
just so they can kind of, have some similarities.
Yeah. So when the exercise is going on, what kind of monitoring are you doing?
So our cardiac patients all wear heart monitors.
Okay.
And it goes to our computer, and we watch their heart rate and rhythm the whole time they're in here.
That's great.
Also go around, take their blood pressure, and make sure all of those numbers look great.
Yeah.
Pulmonary patients will wear a continuous pulse ox, so we can
Okay.
watch their oxygen the whole time they're in here.
Yeah.
And then we do their blood pressures as well.
Great. So really kind of watching them get better in real time.
Yes.
That's great.
Yeah. And then we also do what we call 6-minute walks.
Okay.
We do it when they first start and when they end. And then that way we can see that they've, made a lot of progress.
Yeah.
And we get quite a few patients that can walk a couple hundred more feet than what they started with. So
that's amazing.
It's amazing to see those.
Yeah. Do you have any success stories you want to share?
I have a couple.
Okay.
Both of them have been lung transplant patients.
Wow.
I have seen them before their lung transplant in here and after, and it is amazing because both patients were maxed out on oxygen, received their lungs, and came bebopping in like 18-year-old men, and on room air, never dropped below 99%.
Yeah.
And just their demeanor changes too. It's amazing.
I'm sure with that quality of life change, it really transforms the experience of living.
Yeah.
So that's amazing.
It is.
I'm sure it's incredible to kind of watch that happen and to be a part of that. How cool.
It's nice to see full circle.
Yeah, absolutely. Yeah. How long might a patient, if they're kind of going through pulmonary rehab or cardiac rehab, how long might they be in a program like this?
So our cardiac patients move a little faster.
Okay.
If it's just like a stent, usually they're only in here 4 or 5 weeks.
Okay.
Or we usually say 16 to 18 sessions, because not everybody can attend 3 days a week, because usually we have them attend Monday, Wednesday, Friday.
Okay.
Our open hearts take maybe a little bit longer, like 18 to 24 sessions.
Okay.
Our pulmonary patients, they're usually in here 24 to they can do a max of 36 sessions.
Okay. Wow. What about family members? Could a family member come and sit with, be here in this space during the session?
Yep.
Okay.
They're allowed to come. We do ask that they just sit back on some
comfortable chairs.
Yep.
Yeah, that's great.
Okay. They're not allowed to get on the equipment, but yes, we encourage them to come and watch.
That's great. Yeah. Well, thank you, Lacey. You're doing great work here. I know your team is just so integral. We could not have this hospital without you guys. So thank you for the work that you're doing.
Thank you.
We are here in our sleep lab, not as commonly known of a place in the hospital. We are on the second floor in the short stay rehab. There is a sleep lab right here at Hillsdale Hospital. You can see the bed behind me, and this is one of our rooms where we do the sleep studies. And I'm here with Tracy from our cardiopulmonary team to tell us about the sleep lab and a little bit about what you do here for patients. So please introduce yourself first of all.
My name is Tracy Taylor. I'm a registered respiratory therapist. I also work in the sleep lab. I've been at the hospital 28 years and counting.
Amazing. I know that a lot of our community will know who you are, and they've probably seen you on a billboard before, maybe.
I've done the pictures, yeah, for all that, yeah.
But we appreciate it. So Tracy, tell us a little bit about the sleep lab. What is the kind of service that this center provides, and is it part of the cardiopulmonary department? Is it part of pulmonology? What role does it play?
It's part of both, actually. It's part of cardiopulmonary. I do the tests along with our sleep sonographer, Carol.
Okay.
I generally do the day shift tests.
Sure.
She does the night shift. And it's falls under the cardiopulmonary.
Okay.
I don't want to say
yeah,
tier, I guess.
Yeah, under the department. So when a patient is coming to get a sleep lab, how is that typically ordered? How does it come about that they end up here?
When they come to the hospital, we ask a series of questions, which helps us determine if it's something that's needed.
Sure.
Then we refer to their doctor, or they refer to their doctor.
Okay.
Generally, if your BMI is over 35, you snore excessively. And when I say excessively, I tell people, like, is your spouse elbowing you, or you're like almost shattering windows, because it's some people just snore and some people really snore.
Yeah.
High blood pressure, and then generally males. That's part of it. It is.
Okay.
And then your BMI always plays a part too.
Okay, so so we kind of screen patients when they're in the hospital, and then I'm assuming it's something that primary care providers can also order for their patients.
Yeah, all physicians can order it. It just insurance basis depends on if you need to see a sleep doctor before you can have it done.
Okay.
But there's always a sleep doctor reading it after the test.
Gotcha. Okay. And then do patients also come from the pulmonology department?
Yes.
That outpatient clinic at Three Meadows? Okay.
Yeah. Yeah.
And then once they get here, so are all of the sleep studies done here, or do we do some at home as well?
We have both.
Okay.
Again, insurance kind of determines which way we go. And then what they see on like our screening, I think, plays a part too. If it's just like, we're not so sure, they'll do a home sleep study, which you come in. We have, I think, 2 slots Monday through Thursday in the evening.
Okay.
You can come in, and Carol will talk you through how to do it, how to put it on, go home, sleep with it, bring it back in the next day and drop it off.
Yeah, so it's just equipment that you take with you that kind of...
just a little box that sits on your chest while you sleep.
Oh, wow. That's
you have a pulse ox and a thing in your nose, like a cannula, but it's not it's not oxygen, it's just to determine your flow.
Yeah,
through your
nose. Like a sensor of some sort. Okay.
And
then tell me about the process here when it's kind of a sleep study that we do in the hospital.
Yeah. Well, you can have the home sleep study and then also come into the hospital.
Okay.
If your sleep index is too high on that particular test, they'll have you come in and see us. You come in, you of course talk to the scheduler, you get scheduled, you come in. We will bring you into a room. We're generally set up.
It's very comfortable in here.
It is. It's a very nice room. The beds, I have a lot of people that are love the beds. I've had people take the bedding off to see the brand of bed before.
Oh, that's so funny.
And I'm like, what are you doing? Like, I want to know what kind of bed this is. Yeah.
Of course.
Our beds their sleep numbers. So we have soft to hard. They go up, they go down. They move all over.
This is some high tech.
If somebody has to lay upright, we can put them upright. If their feet have to be elevated, we can do that.
Great.
We have oxygen available if they need oxygen. And then our box.
Okay.
That we hook up. This is the hookup.
This gets hooked onto the patient.
Yep.
Painless, easy.
Yep.
Just takes a little bit of time, and then they sleep with this on.
Yep. Takes us about 30 minutes.
And then what are you doing while the patient is sleeping?
Monitoring their sleep. Generally, we make sure the leads stay on. And then we're also we are watching to see what stage of sleep they go into.
Okay.
And we're looking for that sleep index again, the apnea index again, to see.
And tell me about that. What is the sleep index?
So you have to have so many events, is what they call them, and each event has its own almost definition. Like we have straps on your chest and around your belly. If that goes down 10% of a normal breath, then that can be counted as a event.
Okay.
DSATs, when you're sleeping, can be counted as an event. There's a lot of different things we're looking for, and you have to have so many events, during the sleep study before we can say, yes, you have sleep apnea, and yes, we need to put you on a machine and try to correct those events.
Okay. So any kind of interruptions in what would be considered like a normal. Okay.
And if it's like sound interruptions or anything like that, that doesn't count.
So you mentioned DSATs. What is that?
Any oxygenation desaturation below 3%.
So when you're not fully breathing in the way that you should be.
When you're not taking a big breath or a normal breath, you tend to just teeter down a little bit. We let you go to about 88%, and then we start working on getting you back up. Most people will go down and then they come right back up. That's just what we do at sleep. We don't take as big a breaths when we sleep. And we take fewer breaths when we sleep. So that's normal to go down a little bit. You just kind of got to watch and see if people come back up. If they don't, then you have to step in and try to help them. If they do, they do it every night.
So what kinds of diagnoses kind of come out of this experience?
You can have just sleep apnea. We have narcolepsy, which is the night shift study, and you come and you stay for the it's called an MSLT during the day. That's a little more detailed.
That's another test.
You can have central sleep apnea. There's a lot of different things.
And they're all kind of breathing related to your cardiopulmonary. What about something like insomnia? Can that be something that we kind of take into a sleep study for?
Sometimes people will think they just can't sleep. And it's really, there's a reason behind it. Rather, you are getting to sleep and then you're waking yourself up. We have a lot of people that'll come in and they're like, I'm up all night long going potty. And we get them on a CPAP machine. They don't get up once. And they're like, I thought I was getting up to go to the bathroom. No, you're waking yourself up because you had sleep apnea. You were stopping breathing. And you just assume, excuse me again, I have to get up and go to the bathroom.
Thank you for tuning in to another installation of our Hospital Rounds series with Cardiopulmonary today. If you want to reach the pulmonology clinic to set up an appointment with Dr. Martinez, call 517-437-8366, or you can visit hillsdalehospital.com/pulmonology or hillsdalehospital.com/cardiopulmonary to learn more about these services. Tune into our podcast, Rural Health Today, at ruralhealthtoday.com or wherever you get your podcast. And follow along with our social media on Facebook, YouTube, LinkedIn, Instagram, and Twitter as well to stay up to date on healthcare in Coastal County. And until we see you again, stay safe, stay healthy, and remember, rural health strong.